Are you or someone you know having shoulder pain? Have you been experiencing this shoulder pain for weeks, months, years? If that's the case, we're talking about chronic shoulder pain. You may have been to a physician and diagnosed with bursitis, tendinitis, or even a rotator cuff tear. So what do these diagnoses mean, and what does it take to cure your pain? I'm Dr. Jed, physical medicine and rehabilitation. I've been practicing medicine for more than 15 years and actively studying and reading about the human body for more than 40 years. Let's talk about these issues. I find it useful to arrange the shoulder pathologies in a continuum of pain, in somewhat of a stepwise progression from bursitis and tendinitis, the tendinopathies, followed by the rotator cuff tears. So why does one develop pain? At the most fundamental level, it is when the stresses to the tissue overcome the body's capacity to heal. In an acute situation, it may be a traumatic event such as a fall, a car accident, or any number of events that suddenly increases the load to the tissues greater than the tissues can modulate or deal with. You may end up with acute injuries such as fractures, dislocations, subluxations, complete ligament, tendon, or muscle tears. Today, however, we're focusing on chronic shoulder pain. While there are many causes of chronic shoulder pain, by far and away, the most common causes are bursitis, tendinitis, the tendinopathies, and rotator cuff tears. Within the mid-range, the tendinopathies, there are many stratifications of tendinopathy. You might have a little, you might have a lot, you might have tendinosis, and even calcific tendinosis. To better understand shoulder pain, we need to explore the anatomy and function of the shoulder. To begin with, what is commonly thought of as the shoulder joint is anatomically called the glenohumeral joint. The glenoid is a shallow socket at the end of the scapula or the shoulder blade, which attaches to the head of the humerus, that is the arm bone. The shoulder is an exquisite work of art and biomechanical engineering. The shoulder allows supreme mobility, facilitating many tasks such as reaching up to that top shelf, placing something in your back pocket, from hugs, high fives, to even throwing a punch. This incredible mobility needs to be supported by dynamic stability. If the shoulder was too statically stable, then it couldn't move, and then we couldn't perform all the functions that we require of the shoulder. This dynamic stability is provided by the rotator cuff. As the shoulder moves, it needs to be supported throughout its range of motion by carefully timed activation of the rotator cuff muscles. The rotator cuff provides dynamic stability at the glenohumeral joint, while the scapular stabilizers provide stabilization closer to the spine by anchoring the shoulder blade close and on the body. When the rotator cuff and scapular stabilizers are all functioning as intended, then the human machine functions smoothly and without pain. Once again, injury occurs, chronic pain develops when stresses to the tissue overcome the body's capacity to heal. Chronic stresses can begin somewhat acutely by doing a big weekend project, maybe by taking up a new hobby such as kayaking, or even a new desk set up at work. All these activities can begin to cause agitation, irritation, inflammation, and begin the pathologic process and unfortunately progress your body from bursitis, tendinitis, to the tendinopathies, tendinosis, perhaps even calcific tendinosis, and eventually to rotator cuff tears. Returning to the steps of pathology and pain, I place bursitis and tendinitis at the lowest steps, as their clinical presentation and treatment is virtually identical. While it is true they are anatomically distinct structures, the bursa and the tendon almost always become irritated together, so almost everybody that has subacromial bursitis will also develop rotator cuff tendinitis. Returning to the anatomy, the humerus, that is the arm bone, sits just beneath the acromion. The acromion so to speak, makes the roof of the shoulder and the rotator cuff, this is the supraspinatus, that is the infraspinatus, come just beneath the acromion, attaching to the humeral head and acting as a stabilizer throughout the motions. Now, as you can see, the rotator cuff just beneath the acromion right here, and it is somewhat susceptible to friction, irritation, agitation. To protect it from these excessive friction and excessive forces, the bursa lies just beneath that surface. Unfortunately, if chronic stresses begin to irritate and agitate the areas, the bursa becomes irritated, thickened, which then begins to pinch and perhaps even impinge into the subacromial space. You then have subacromial bursitis. You've then irritated the rotator cuff tendons, and if you have developed an anatomic hypertrophy, that is an overgrown and degenerative, perhaps an arthritic acromial clavicular joint, that can even sometimes be poking right down into the supraspinatus itself. Some people anatomically are just born with an overgrown acromion. There's a type 1, a type 2, and even a type 3 acromion that is sometimes called the hooked acromion, where a little bumps and bones literally poke into the supraspinatus tendon, causing ongoing insult to injury, you might say. If a person has developed subacromial bursitis, rotator cuff tendinitis, and perhaps developing impingement, you may experience what is called a painful arc. And that is when part of the bone essentially impinges and grinds and increases the force and hurts right there beneath the acromion. It pinches the bursa, the rotator cuff tendons, into the acromion. If mechanics are not restored and stresses continue to be in excess of the body's ability to heal, then the pathology progresses. The next stage of the pathologic progression, the middle steps, if you will, are the tendinopathies. Tendinopathies are essentially when the tendon itself begins to degrade, begins to get scarred in, and becomes a dysfunctional tendon. This progresses from maybe just small spots of tendinopathy, tendinosis that you might see on an MRI. Unfortunately, these scarred in tissues, which is now called tendinopathy, is not equivalent to good, healthy tendon. It no longer conducts forces smoothly. When you look at the rotator cuff tendon using an ultrasound to provide an injection, typically you should see what is called fibrillar in nature. That is these long strands of collagen nicely arranged. When you are performing an injection or doing an ultrasonic evaluation, you may see thickened and darkened area. That is tendinopathy, tendinosis. This is essentially scarred in tendon, which is now dysfunctional. It does not conduct forces well, it causes pain, and furthermore, the thickening of the tendon now causes more inflammation, irritation, agitation at the rotator cuff itself. As the wear and tear continues, you may even eventually begin depositing calcifications there. You may develop calcific tendinosis. Here's an x-ray of one of my patients that had a little bit of calcific tendinosis, and then one that had more calcific tendinosis. The thing is, once you've developed calcifications, calcific tendinosis, it becomes exceedingly more difficult to treat without interventional measures. As these pathologies progress, you will develop rotator cuff tendon tears, and there is a lot of overlap between the rotator cuff tendon tears and the tendinoses, the tendinopathies. Most tendinopathies, particularly advanced tendinopathies, will have lots of maybe micro tears that you could maybe just barely appreciate on a high Tesla magnet MRI or appreciate on high resolution ultrasound. These rotator cuff tendon tears may progress to partial thickness tears, perhaps even longitudinal splitting. They can then progress to a complete thickness tear, and then the last progression is a complete thickness tear with a through and through tear, and even with retraction. So that is a brief overview of the common causes of chronic shoulder pain. from bursitis tendinitis, the tendinopathies, tendinosis, calcific tendinosis, and the rotator cuff tears, be they micro tears, partial tears, full thickness tears, or complete rotator cuff tears with retraction. Well, what do you do about it? As a very complex topic, we'll dive deeper into the specifics of treatments in future videos. However, to give you a brief overview, anything short of a complete through and through rotator cuff tear will typically respond well to conservative measures. You will oftentimes begin with relative rest, perhaps a short course of anti-inflammatories, the NSAIDs. I've got a video out there that talks about appropriate use of NSAIDs when necessary. Sometimes people will respond well to a steroid injection. In fact, if you've never had one before, you'll typically respond very well the first time, perhaps in the future. However, you don't want to do too many steroid shots because the steroid itself can be somewhat toxic to the tendons and in the long run, somewhat unhealthy for the healing body. Most importantly is targeted rehab exercises to restore proper mechanics. These exercises, of course, can be done with the guidance of a physical therapist. However, it can also be effectively accomplished through careful online guidance. On my website, drjed.com, I have progressive rehab from level 0, 1, 2, 3, 4. Now my level 0, level 1 are specifically for my patients that have undergone what is called a percutaneous tenotomy, but for the general population with these chronic issues and short of a complete rotator cuff tear, typically begin with maybe level 2, progress to level 3, and level 4 is tolerated with specific attention to the level 4 scapular stabilization exercises. I hope you find this video useful in understanding the pathologies that can contribute to and cause chronic shoulder pain. If you liked this, give me a like, hit that subscribe button, go ahead, take care of yourself and be well.